before we delve deeply into new interventional treatments for peripheral arterial disease, to speak just a moment about medical interventions that have the potential to save not just limbs, but also lives. So when we talk about strategies to manage the peripheral arterial disease patients, we're talking about a whole wealth of different strategies. But what I want to focus on in the precious few minutes that I have to talk about this is developments in the last year or two that have the most impact, will have the most profound impact on the management of our patients. And that has to do with lipid management and high-intensity statin therapy and the introduction of the new class of agents, the PCSK9 inhibitors. Update recently to the cholesterol guidelines. We'll talk about antiplatelet therapy, or should I say antithrombotic therapy, and we'll talk about dual pathway therapy, which is the combination of a low-dose DOAC, Rivaroxaban, with aspirin. And in the final moments, I'm going to just present some interesting data which I think will surprise you about blood pressure regulation in our patients. So we've known since the days of the heart protection study that administering statins to our patients saves lives. And this applies to the patients with peripheral arterial disease more so than any other patient subset. Yet we still don't do it. This is a study from just last year looking at the National VA database. And you can see that when patients have coexistent coronary artery disease, the vast majority of them, 84%, are on some form of statin therapy. But with isolated peripheral arterial disease, only 40% of the patients, only 60% of the patients are on statin therapy. A full 40% of the patients are not on statins, and only a small percentage, less than 6%, are on high-intensity statin therapy. And that's despite the fact that there's a 20% decrease in mortality and a 20% decrease in amputations in this patient set on low to moderate intensity statins, and a 30% decrease in mortality and a 40% decrease in amputations when patients are treated with high-intensity statin therapy. This is the group from UC Davis that looked at their patients who presented with critical limb ischemia a few years ago, 2/3 of which of these patients ended up on some form of statin therapy. And they noted not just freedom from major adverse coronary and cerebrovascular events in the statin-treated patients, not just freedom from death, increased survival rates, but they also noted freedom, decreased amputation rates in their patients who were treated with statin therapy. And in those patients who went on to infrapopliteal arterial interventions, which the majority of these patients with CLI did, they saw increased patency rates in the statin-treated patients, no matter whether it was primary assisted, or secondary patency rates. But this is a retrospective observational trial, and there are a number of these retrospective observational studies. We've seen that statins can reduce cardiac and vascular complications after AAA repair, after bypass surgery, after carotid stenting and carotid endarterectomy. We see that statins can lower stroke. We can see that statins can slow the progression of Alzheimer's disease and even increase wound healing rates. The majority of these studies, however, were retrospective and observational, and randomized data up until recently was pretty scarce. And now we have the introduction of the PCSK9 inhibitors. These monoclonal antibodies were introduced in 2015, but it was only in the past year or two where outcome data is emerging that demonstrates the clinical benefit of lowering cholesterol with these agents. And one such study was the FOURIER trial, 27,000 patients. Most of these, or all of these, were on some form of statin therapy already, randomized between study drug, Evolocumab, or PATHA, or placebo, with the primary endpoint, the typical composite of coronary artery events, but they also looked at major adverse limb events defined by acute limb ischemia, major amputation, or the need for urgent revascularization. And you can see there was a dramatic drop in LDLs down to a median level of 30. And this was associated with a modest benefit in cardiovascular outcomes. But they also looked at the patients with peripheral arterial disease, and you can see that in patients with peripheral arterial disease, these are the patients who are at the highest risk and stand to gain the most benefit. And I think it's interesting if you look at the patients with isolated peripheral arterial disease, in other words, PAD without coexistent coronary artery disease, these patients are at higher risk of a cardiac event than of the patients with cardiac disease and no peripheral arterial disease. They also looked at major adverse limb events, and they saw dramatic reductions in urgent revascularization, hospitalization, or amputation rates in their overall patient population, and specifically in the patients with peripheral arterial disease. How low do you go? Well, it seems like in this regression analysis that, that there is a linear association with lower LDL and lower event rates down to about an LDL of 10. So the guidelines were updated. Symptomatic peripheral arterial disease, still considered a major cardiovascular event. In patients who are at the highest risk, now numbers are back in the guidelines. 70 is a threshold for considering additional therapy. The recommendation is to start with maximally tolerated statins, add ezetimibe, and if there is still a threshold above 70, then it is reasonable to add the PCSK9 inhibitors. So let's move on to the platelet. The schemes illustrated here are the coagulation cascade as well as platelet activation, and we tend to think of these as independent pathways, but there's a common denominator, and that's thrombin. We think of thrombin as the final step in coagulation cascade, but thrombin is also a very potent activator of platelets through its effect on the PAR1 receptor. So this hypothesis of anticoagulation therapy was tested again in the COMPASS trial. Patients with documented coronary artery and peripheral arterial disease were randomized into one of 3 treatment arms. Single aspirin monotherapy, low-dose aspirin, 100 milligrams a day, a low dose of Rivaroxaban, 5 milligrams a day, 5 milligrams BID, which is roughly half the dose that we give for atrial fibrillation, and an ultra-low dose of Rivaroxaban, 2.5 milligrams PO-BID, in combination with aspirin therapy. What we saw was a dramatic decrease in cardiovascular events in the combination therapy arm, a 24% relative risk reduction. And the investigators also looked specifically at their PAD patient subset, about a quarter of the patients, and they saw even more dramatic drop in major adverse cardiac events in this patient population. They also looked at limb events and saw decreased amputation rates in that combination therapy arm. Combining the endpoint between major adverse coronary and major adverse limb events, you see also dramatic drop in event rates. And this did not come without a cost of some bleeding. Major bleeding rates were increased. However, fatal bleeding rates and bleeding rates into a critical organ were not increased in the combination therapy arm. So based upon this data, it's suggested that for every 1,000 patients treated over a 21-month period, we can save 27 major adverse coronary events or major adverse limb events, including amputation, for every 1 fatal or 1 critical organ bleed that is suffered. I talked to you about the fact that we were going to mention a little bit about blood pressure regulation, and this is an interesting reanalysis of the landmark ALLHAT trial. And it's clear that with systolic blood pressure, we have increased increased event rates with high blood pressures. But it's interesting to note that looking at systolic blood pressure, too low also affects our hazard ratios, as patients can have increased event rates when blood pressure is too low. And as far as diastolic blood pressure, also a relationship to low blood pressure and major coronary event rates. So in conclusion, peripheral arterial patients are at highest risk of major adverse coronary events, as well as major adverse limb events. Emerging therapies have demonstrated a reduction in male as well as MACE. And PAD and CAD do not always behave the same, and more studies addressing the specific needs of the PAD patient population are needed. Thanks.